We're going to have you, so follow my finger with your eyes, keeping your head still. There we go. Don't anticipate it's going to move at different speeds, and then more quickly. Good. Now I want you, while you're focused on my finger, now look quickly at my nose. Now back at my finger, nose, finger, nose, finger, nose. It's important to evaluate the smooth pursuit system, especially subtleties of smooth pursuit, and you want to move both quickly and slowly, but initially, so follow my finger again, just like that, and then you want to go a little more quickly and stress her, see where she breaks down, where she starts to make coarse movements. So far there are no smooth pursuit abnormalities here at all. So if the smooth pursuit system is normal in the horizontal plane, then you want to check the saccadic system. So focus on my finger, now my nose, finger, nose, finger, nose. This would be one of the best ways to bring out a subtle intranuclear ophthalmoplegia. So that's just kind of in general. Now, a couple other things we're going to do as far as the examination. I'm going to check just some color vision. And so initially, we're just going to have you focus right here on the red saturation. And you look right there and tell me about the brightness of the color. Is it brighter in that eye, brighter in that eye, or about the same?
It's brighter in the left.
Brighter in that eye. So then we want to quantitate the red brightness. So if that's 100% or $1 worth of red brightness,
Right.
how much is that? That's 100. What's
About
that?
75%.
So that's $1, that's 75 cents.
Cents.
Okay, so
Right.
about a 25% red desaturation in the left eye. And it's be also a good idea to get a general sense of visual fields. So red saturation is really important from eye to eye. I want you to cover your left eye and just block the vision with a hand. Focus right on my nose here. And when you look right at my nose, tell me how many fingers you see.
2.
They're going to be quick, okay?
1.
How many? You see
2.
it up there?
Mhm.
Okay. How many there?
1.
How many there?
5.
How many there? Too quick? How about there?
That was 10.
Okay. So do you not see quite as well up in here?
I don't see.
Yeah, no, you seem
peripheral
to have a little more trouble kind of
Right.
capturing.
And that's what that
capturing-
field of
capturing
vision
up there,
test
yeah.
has showed.
And that's from your ophthalmologist,
Mhm.
okay. Switch hands there. Look right at my nose again. Do you see all of my face? Any parts missing or blurry? Okay, so looking at the central vision, central part of your face is about, my face is about the central 10 degrees of somebody's vision, so that gives you a pretty good sense of, for central scotomata, if there's any abnormalities in that central part of your vision. And that's also the stuff you would notice the most in the central. And we're going to try a little something here. I want you to focus right on my nose, and this little red target, we're going to make that go away. So tell me when it's gone.
It's gone.
Gone. Okay, so keep focused right on my nose, and then tell me when you see the red, not the white or my finger, but when you see the red.
I see it.
Okay. What I'm doing right now is mapping out her
See
blind
it.
spot. And you get a general sense, if you do this a little bit, and by the way, this is all should be done at about 1 meter, and I know my arm to my nose from here to there, and your chin is about 1 meter. So just look right here, and we make it go away. It's gone?
It's gone.
Okay, tell me when you see the red again.
I see it.
Okay, so that's actually maybe a little bit generous blind spot in the eye. Switch eyes or hands. Same thing, look at my nose. Let's make that go away.
It's gone.
Okay, now keep focused right on my nose. Tell me when you see it again.
I see it.
Okay, tell me when you see it again.
It's gone. I see it.
Okay, tell me when you see it again.
I see it.
And tell me when you see it again.
I see it.
Okay, so blind spot may be a little bit enlarged there, but not too different from the other eye. Now, what about up here? You see any differences up here? Do you
No.
see the red color? Does it look red to you here? This is kind of where ideally you'd have 2 red saturations and we could compare them side to side. You really need the same color. It's got to be pretty much identical. So, all right. So then the other parts of the so that's basically going to be the kind of confrontation. Then the pupil exam is going to be more like this. So I want you to do is just look straight ahead for me. Normally we'd do this in dim light. In fact, you want to try it and see if you can get it. Okay, so pupil exam, have patient fix in the distance. If they fix up close, you may see some constriction of pupil due to the near response where the pupils will contract. So fix in the distance. Initially, you examine the pupils from below, and what you're really looking for is symmetry. Are the pupils round? Are they equal? Are they the same? Are they essentially equal between eyes? And then you watch a little bit for what's called physiologic instability, or something called hippus. So this is more common in younger people, but we also see it if someone's a little anxious. The pupil sort of bounces up and down a little bit, and that would be a normal finding. So then you examine the two phases of pupillary constriction, or two phases of pupil reaction. Is the initial constriction phase, and then what's called pupillary escape. So when you initially shine the light in the eye, the pupil contracts, and then there's a little bit of correction. So we'll watch that in her eyes to see if we can see that little bit of dilation. Basic pupil examination starts with a little observation. You do this in a dimly lit room, and you initially begin with illuminating both pupils from below. And initially what you're looking for is size of pupils and symmetry. And while you're observing from below, you're also looking to see if there's any physiologic instability of the pupil, hippus as it's called. The pupil sort of bounce up and down a little bit. Hippus can sometimes interfere with your ability to detect or measure a relative afferent pupillary defect. So initial examination, illuminate from below, and her pupils look fairly symmetric. We can measure that, but they're approximately 5 to 6 millimeters. There's a little bit of hippus, and hippus, of course, is going to be worse in younger people and if they're anxious. It's a benign condition. It's physiologic. So, and then you examine each pupil individually. There are two phases to pupillary constriction. There's the initial light reaction, and then there's a brief redilation, what's called pupillary escape. When you're trying to measure a subtle afferent pupillary defect, it's important to get a sense what that pupillary escape is in both eyes. When there's a large, obvious afferent pupillary defect, it's easy to see. It's the subtle ones, and typically in MS, unless they're in the middle of an optic neuritis attack, the afferent pupillary defects are not going to be very large. They're going to be very subtle and hard to see. So I'm sorry, this is Greek to you, but
I'm learning.
So just talking about how we examine
Sure.
the pupil and some real subtleties of things that may be present in persons with MS, and help others to be able to kind of pull out some of those subtle things to help them treat and diagnose people with MS better. So now, individual pupil exam, you just simply illuminate from below, and then you watch the initial constriction, and then there's a little bit of escape. She has some hippus there too. So initial constriction, and then there's a little escape. Check the other side, initial constriction, and then a little escape. Initial constriction, a little escape. And what I'm looking for right now is not the initial constriction. I'm comparing from eye to eye how much pupillary escape she has. And if there's a difference in the escape, that can be the most subtle part of an afferent pupillary defect. Then, once you've done that part of the examination, you're ready to do the swinging flashlight test. So here, the concept is we're comparing the light reaction in both eyes. So one optic nerve to the other. So illuminate, swing, and you're looking to see if the pupil dilates and enlarges. Swing. Now I do a little cadence in my head. It's like a waltz step. I do a 1, 2, 3, swing. 1, 2, 3, swing. And the purpose of why I do that is I don't want to keep the light too long on any one pupil. If I'm up here looking at something and trying to decide about a pupil, you're photostressing the retina. And if you do this a whole bunch, you're actually, for a subtle afferent pupillary defect, that retinal photostress will bleach the retina, and you won't even be able to measure a subtle afferent defect. So you have to kind of give them a break a little bit from the bright lights. Now, one important technique if somebody has hippus, so there is just a little bit, I'm not sure if you can capture it on camera, but there's a difference in the constriction and the swing, and she's quicker to escape in the left eye. So essentially what I'm seeing, you may not be able to capture, is when I shine the light in this eye, the pupil constricts. Both pupils constrict the same. When I swing it to the other eye, from the right eye to the left eye dilates a little bit. So the concept there is that your optic nerves, the light that your eyes process, is summed together in your brain. So when you shine the light in one eye, both pupils react the same. If you swing the light to the other eye, both pupils should react the same. If there's damage in one optic nerve, let's say your right eye sees 100 units of light, but your left eye only sees 50 units of light. When you shine the light in the right eye, both pupils, your brain sees 100 units of light, tells both pupils to constrict this much. Now, if you quickly swing the light to the other eye, and this optic nerve on the right side is only seeing 50% of the light, when you swing the light, pupils will actually dilate, and both of them will dilate. So that's based on the anatomy and how your optic nerves cross and where the light fibers go in the brain and all that. So subtle afferent defects, and it appears you have a small afferent pupillary defect that's sometimes called a Marcus gun. Your ophthalmologist might call it a Marcus gun pupil. That usually means that there's damage in one optic nerve greater than the other. If both your optic nerves were damaged the same amount, the pupils would react the same amount, and that test of swinging the light back and forth would be the same. Usually in MS, there's damage in both optic nerves, but it's often asymmetric, that one optic nerve has a little more damage in it than the other. We're going to do an OCT later and compare to your OCT you had done several years ago.
Okay.
The OCT will measure the thickness of the nerve fiber layer in the back of your eye, and that should be pretty symmetric. Your optic nerves are pretty normal in their structure in terms of how you were made,
Right.
but there is some damage in your optic nerves that are a little bit pale. All right, so the optic nerve examination is important. So initially what you want to make sure that you do is you want to do all the parts of the examination that require the patient to have good visual acuity. So I don't want to shine a bunch of lights in your eyes and then say, how bright is this red color? Because it'll wash it out.
Right.
So in terms of ordering the examination, you do all those things that require acuity initially, and then you do the things where you're shining lights and things like that. So the ocular motility, the eye movements, the confrontation visual fields and all that we do in bright light, and then we dim the light, start shining lights in your eyes. Now I'm going to examine your optic nerve, so I want you to look off in the distance. So the optic nerve exam, at least old school when you're using a handheld ophthalmoscope, it's important to kind of ground yourself, get the light, and instructed residents many years on how to hold an ophthalmoscope. The technology is moving on now, so there are panoptics. There's a panoptic around here somewhere. So you can use a panoptic, which gives you a wide view. I'm actually better at using this than I am the panoptic. It's just old school. So initial optic nerve exam from about this distance, hold. That's sort of the standard. One finger, you want to be able to work that. This finger's your bumper, because you need to get, with small pupils especially, you need to get really close to the eye. The closer you get to the eye, the more that pupil, the more field of view you will have when you look in the back. So initially from right here, and I'm able to get a red reflex, I can see the glow of her retina, and if I keep that red reflex in vision as I advance, I'm keeping this finger out, so I'm not going to crash into her. And I have my hand on her shoulder, so for my own balance. And then we get right in there. Okay. Now, something else I want to show you. I'm coming exactly 15 degrees from her fixation. So she's looking straight ahead, and the angle I'm taking is in trying to stay in the same plane of her vision, but 15 degrees off her fixation. And the reason is, that's where the optic nerve is. So it's kind of hard to find your way around in the back of the eye. So it's always important to find the optic nerve. And then once you find the optic nerve, then you follow blood vessels out into the periphery. And then you can follow from the optic nerve. If you go nasally, you're able to see her macula from straight on. So first, you get the landmarks. First thing, red reflex. And then as I get closer and closer, and I can literally plant my finger right on her cheek, and then I can use that to pivot so I'm not falling all over the place. Now, once I get in that close, I need to focus on something. What I'm trying to do is get a blood vessel in focus. And as soon as I can see the blood vessel, I want to find a bifurcation of the blood vessel. Why? Because it points to the optic nerve. So if you see a bifurcation of the blood vessel, go like in that direction, follow the blood vessel that way, it's going to lead to the optic nerve. And I'm pretty much right on our optic nerve now. Then once I'm on the optic nerve, I kind of just pivot around and look at it. And the place you want to look for most carefully for MS-related damage in the optic nerve is the temporal portion of the optic nerve. That is preferentially affected in persons with MS. So you have a little bit of temporal pallor in this eye. It's just a focal segment of temporal pallor. And then I can pivot around and see a few blood vessels. I won't do the full peripheral exam. Most of what's important in MS is going to be the optic nerve and the macula. And that macula is in the center of your vision. So you do the same exam on the other eye. And this is pretty important. There's a lot of anomalous structures in optic nerves. Everyone's a little different, big surprise. But you're born with slightly different structures or shapes of your optic nerve. In some cases, people have an unusual structure of the optic nerve. About 10% of people have a really unusual structure of the optic nerve, and that might mask some findings of optic neuritis or a remote damage in the optic nerve related to MS. It's really important to compare one optic nerve to the other, and I'm looking at both the structure of the nerve, but I'm also looking at differences in pallor. So a healthy optic nerve should be sort of a waxy, or should be more of a pinkish color. A damaged optic nerve takes on kind of a waxy yellow appearance. So it's important then, look straight ahead. And now I'm just going to compare back and forth, and I have to kind of keep a memory. Of what our optic nerve looks like. Switch hands to do the other eye so you're not face to face with them. I want to get to know you, but not that well. And yeah, and this eye actually has more temporal pallor than the other eye. And that would certainly make sense given the fact that she has the afferent pupillary defect in the left eye, or the Marcus Gunn pupil is on the left. So that's pretty much exactly what we'd expect. So initially, we're going to do an ocular motility examination that's a little more focused on the types of issues that people with MS have. The most subtle eye findings I find in someone who has MS is actually a smooth pursuit problem. And usually in the horizontal plane, much more commonly in the horizontal plane than in the vertical plane. Smooth pursuit system and the saccadic system, two separate systems in the brainstem. And you want to check them both. You may find patients that have subtleties in smooth pursuit, and you want to stress the system a little bit. So I'm going to start off a little bit slow, but try not to anticipate. I'll go a little faster. I may be a little erratic. I just want to make sure you're not anticipating and jumping ahead. I'm going to check your vision a couple different ways, and then we're going to do something called confrontation visual fields, which will check your peripheral vision. But this is now about just simply your eye movements. So first of all, just focus right here on my finger and follow my finger with your eyes. Try to keep your head still. So initially, I go very slow, and I'm just watching, is she tracking? Are the eyes symmetric? If you did have some concern about does she have double vision or subtle double vision, you can actually look for the reflex off her cornea and kind of see if it's in the same part of her pupils. I'm not sure if that will demonstrate too well with this light. Let me try it with this one. So if you see where the light is in the center of her pupil, and actually you are deviating a little bit, your left eye is actually a little bit out. Are you seeing double or anything right now? Was it getting a little blurry? It got a little blurry there, yeah. Because it initially, look back there, so initially the reflex is in the center of the pupil, and then your left eye drifts just a little. So I hadn't noticed that before. It's just very subtle. And then, so the smooth pursuit system, we start off slow in the horizontal plane, then we go a little faster and a little faster, and you always want to go until they break down. So she's
And by breaking down, I mean, first of all, the smooth pursuit, side to side like this, very smooth. And as you go faster, at some point, she's going to start making catch-up movements. So when smooth pursuit breaks down, people start to use the saccadic system to compensate. So saccades are when you make a volitional refixation. So a saccade would be like this. Look at my finger, now look at my nose. Look at my finger, now my nose. Now what I'm looking for here is two things. I want to see the accuracy of her eye movements, that she's able to accurately get her eyes to my finger and then to my nose and back and forth. And I'm looking very carefully. You can pick up a subtle internuclear ophthalmoplegia by watching the medial rectus or the abducting eye. I'm sorry, the adducting, the adducting eye. So in an internuclear ophthalmoplegia, you will see when in its purest form, an INO would look like this. Looking in that direction, this eye would go out, have coarse beats of nystagmus. This eye wouldn't move at all. In reality, we see subtle variations on the theme, where this eye goes out. You may not see much nystagmus, but this eye goes out and this one just lags a bit. So very, on the smooth pursuit exam, very important that you look at the saccades too, because that's where you catch a subtle INO. Follow smooth pursuit, look for symmetry from side to side. In other words, is she smooth this way, and then does she go clunk, 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 clunk that way? That asymmetry is important and would be abnormal. And then you look again carefully at the saccadic system. And so far I've focused on the horizontal plane. It's important in the vertical plane too, but I don't see quite as much abnormalities in the vertical plane, in part because that is actually in a different area of the brainstem. The INO in smooth pursuit comes from periaqueductal gray, and maybe we can see that on an MRI sometime, but it's a very distinctive area. You'll see that commonly in people with MS. There's a little involvement in the medulla. So initially, I want you to look here at my finger, look way up and way down, and again we're looking for, do you see double anywhere here? Or here? Or here. And then you ask about subjective diplopia, and down. And then convergence. So follow, look right at the tip of my finger, and you want to hold them there for a while, because some people with MS are complaining of blurred vision or double vision, and what they have is something called convergence insufficiency. So she's holding her convergence pretty well. Or is it double right there or blurry?
A little bit on the left.
A little bit, yeah.
Mm-hmm.
So good. Okay. Now see one of the parts of. So confrontation visual fields would be a little different, and this is checking kind of your peripheral vision. So there's a couple ways to check confrontation. Cover your right eye with your hand, and I want you to focus right on my nose here. And when you look right at my nose, tell me how many fingers that you see. They're going to be quick.
2, 1, 4.
Okay.
2.
Okay, good. That's other eye, other hand. There we go. Right at my nose here. And how many fingers there?
2.
How many there?
1.
There. Missed it? Yeah, that was an area that's been a problem up there, where you don't see quite as well up there.
2.
And then how many there?
2.
Good. Okay. One other thing we want to do, you can put your hand down now. I want you to look right at my face. When you look right at the center of my face, do you see all on my face? Any parts missing or blurry or less clear than others? And how about that?
I see it all.
Focus right on my nose, and when you focus right on my nose, everything's clear? Good. Many people will do confrontation visual fields in the periphery by doing things like, do you see my fingers moving? Do you see my fingers moving? Right. Most of the neurological issues that we're going to find, be it stroke, be it MS, are going to be more along the midline. So it's important to kind of check in this area. The further you get out, the less reliable your findings are. So maybe it's a good sense to get whether someone has peripheral vision, but for the most part, along the midline is keeping the fingers kind of close to the midline. Okay. And the face confrontation, basically at about a meter, will be roughly the central 10 degrees of vision. And since MS commonly affects the papillomacular bundle, or that portion of nerves between the optic nerve and the macula, that subserves that central 10 degrees of vision. So that's an important thing to check as well. A better way to check central vision is with red saturation. You have concentrations of blue, yellow, and red, green fibers in the macula, and red saturation or green saturation is a very good thing to check. So what I want you to do here, and you want, in general, a well-lit room for this, focus right on the red color there, and I want you to tell me, is it brighter in that eye or brighter in that eye? And I'm going to do it this way here for a second. Brighter there or brighter there?
It's brighter in the left.
Okay, and then it's important to quantitate the amount of red saturation if you can. You might find 5, maybe 10% saturation differences to be essentially normal. But if you get beyond that 5 to 10% difference, so I try to quantitate it subjective with the patient as much as possible. So focus on the red color there. If that's I'm sorry, you said the left eye's brighter or the right eye?
The left eye's
okay.
brighter.
So if that's $1 worth of red or 100% red, how much is that?
It's about 75.
Okay, so that's about a 25% difference, and that's clear. Okay, so a 25% difference would be a little more than expected. And you say it was dimmer in your right eye compared to the left. And that's not quite what I expected, because your optic nerve in the left eye is a little more pale, although you do seem to have an area up here in your peripheral vision where you don't pick up the fingers quite as quick.
Right.
So you can do the confrontation fields in several ways. You can check for kind of this, which I don't find all that useful. But if you do confrontation presentation quickly, which is why I was kind of flashing the fingers, you're able to pick up some of these visual field deficits with a finger count test rather than formal perimetry. If you do detect anything, it's important to do a visual field. So a formal parametric visual field will document how much peripheral vision loss that you have. It's important for people's day-to-day function as well, driving, things like that. Good. Now, and again, whenever you examine the pupils and the optic nerves, you also want to do a careful cranial nerve examination, which we'll dispense for that for right now. But thank you.
Okay, thank you.
Probably want to do a little bit of just the history and the distinction between optic neuritis, and ask you a little bit about your visual symptoms, and we'll distinguish between optic neuritis and ocular migraine. Okay. I don't really need I don't think you'll need close-up. I'm just going to talk to her for
My
that.
mother had macular degeneration.
She did? Okay, yeah.
Is that usually hereditary?
There is a hereditary predisposition, but the OCTs, you do her macula when you do that?
Yeah,
you do.
yeah,
So
it's beautiful.
the OCTs that Dr. Hunter's doing is going
And
to.
then my ophthalmologist checks, he saw her, so he's
Does he
familiar.
do measurements in the back of your eye, or just look at it? Does he do an OCT on you?
Not sure.
Okay. So OCT is probably even more sensitive than your doctor's examination of your eye. And Dr. Hunter's going to be doing that on you pretty regularly. So if you're starting to develop macular degeneration, he's probably going to pick it up too. All right. So tell me a little bit about your visual symptoms. I understand you saw your ophthalmologist, and they think that you might have had optic neuritis in the past.
Yes.
Do you recall ever having an event of optic neuritis?
Well, it's typically been during either possibly a relapse or a migraine episode that the right eye gets blurry or things get dark, very shadowy. And typically my migraines are behind my right eye. So I've always just associated that. I don't know.
And does your vision is dark when you is it usually dark, or do you ever see lights or lines or flashes or
flashes of
zigzag
light,
lines?
like little lightning bugs flying.
Phosphines or photopsias, we call those.
Right, it's both eyes.
Uh-huh.
And so that's kind of been my history with.
Is that a reliable warning that you're going to get a headache?
Pretty much.
Okay.
Yeah.
And so how long do the visual symptoms last?
Through the migraine for sure, and sometimes into the next. If the migraine, the next day, if I knock it out, I'm usually sore for the next day, and that next day it's kind of blurry. And then from a day-to-day basis, I notice that the later in the day it gets, if I get more tired, my vision gets a little more blurry. I'm not able to focus.
Okay, so
to read
you have
and
some
that kind of
fatigue
thing.
effects too.
Right.
Yeah. So have you ever had any events that you can think of where you had a relatively sudden, coming on over several days, worsening of vision in one eye or the other, where there was pain involved, maybe pain when you moved your eye from side to side or up and down?
When the MS came to a head, I was really struggling to see. It's like my muscles in my eyes just wouldn't focus, if that makes sense. I just couldn't.
So as opposed to focus, this would be more an issue in
Painful.
one eye versus the other, usually painful, but where you just wouldn't be able to see as well out of that eye. And it might last a few
Right.
weeks or so. Ever had any
Probably-
episodes like that? Or are they
Probably
mostly
the
been
right
brief?
eye,
Yeah, okay.
and it's been several weeks. And when I do have a relapse, the right eye is a lot weaker.
So a typical event of optic neuritis would develop gradually over 2 to 3 days or so. You might at first notice things just aren't quite as clear, or
Right.
maybe even not be able to say what's wrong with the
Right.
vision in that eye. You might also notice with optic neuritis that the lights aren't as bright, and colors, like with the red color I was showing you, aren't quite as saturated, especially red colors may not be quite as bright red in one or the eye during one eye or the other during that event.
Okay.
So the pain with optic neuritis, usually it can just sort of ache around the eye. 90% of people get pain when they have optic neuritis. Sometimes it's kind of mild.
Right.
It might just be sort of a dull ache around the eye or behind the eye, and that can be confused with migraine sometimes. People get a visual change and then they get a sort of dull ache, and in people who have migraine and MS like you can have an event of optic neuritis that you think is a migraine.
Right.
The main distinction, there's a couple really important distinctions about a migrainous visual event versus an MS-related event of optic neuritis. And one of those things is how quickly it changes, how long it lasts. So a migraine event comes on pretty quickly. So your prodrome before your migraines, that's what, 10, 15 minutes before you get a
Right.
headache? That's fairly typical. As opposed to optic neuritis, where you might notice a little something and then that builds in over a few days, but you would get some pain, and then sometimes people confuse that and they
Right.
think it's a migraine.
I could say that.
The other thing about that we might see in migrainous visual loss is what we call a scotoma, or a blind spot, can develop. In some people, they have a very distinct edge to that blind spot. It might even be bright or shimmering, and it might be sort of zigzag. And now that can sometimes be confused with retinal detachments as well, because what happens with migraine is there's a very slow movement of the scotoma, the blind spot, or if it's lights or lines, or often it's sort of shimmering, or sometimes people
Right.
describe it as like a sensation of sort of heat waves, like coming off the pavement or
It's
something.
kind of
on a hot
like, you
day.
know, when you come out of a swimming pool and there's water on your eyelash and you're just trying to clear it.
Yep.
I have that, so that's kind of that shimmery.
Yeah, if that you have that typically with your migraine symptoms prior to the headache. Yeah,
Right.
That's fairly common.
Okay.
People with optic neuritis don't tend to get that very often. They can get, during an event of optic neuritis, some of the flashes and sparkles that you were describing, phosphines and photopsias, we call those. So they can develop those things too, which again can be a little confusing between a migrainous event and an event of optic neuritis.
Right.
So it's important to kind of keep that distinction in mind. So if your symptoms are brief, if you get a blind spot and it slowly moves across your field, typically that's going to take about 5 minutes or so.
Okay.
And that's probably the most important thing to pay attention to help your doctor distinguish between like a retinal detachment. Sometimes it's like the scotoma will move down. Often it's more across, or sometimes it goes to the midline or stops. Sometimes it starts in the middle and it'll move to one side or the other. And over 10 to 15 minutes, sometimes longer, but usually 10 to 15 minutes, it'll just sort of move on out of the way and disappear. Now, your vision still may take a while to be really completely normal again.
Okay.
But then, as opposed to that event of optic neuritis, where it's painful, the symptoms, the visual symptoms, worsen and worsen and worsen over 3-4 days to a week or so. If we don't do anything about it, it'll worsen for about a week or two, then level off. Your vision loss will sort of stop. And whether we give you steroids or not, over time, your vision will gradually recover, and typically 3 to 6 months, people generally have a near complete recovery, although they may have some residual problems with their vision that include issues with color visions, like you do,
Right.
and something we're going to check here in a minute is your contrast vision. you're going to have your work cut out for you here on this contrast chart, because this is a Sloan low contrast acuity chart, and that's the one we pretty much have standardized on. And be careful, I don't want to touch the surface of these. And it's important to have the lighting in the room standardized. So this would be the 100% saturation, and equivalent to what you would read in your doctor's office, a regular eye chart. So black letters on a white background. I'm going to show you what you're in for here, though. So the next one is a little harder to see. So that's a 2.5% chart, and you see how much dimmer the letters are. So contrast vision is actually one of the most persistent problems after somebody has optic neuritis. So I want to check your contrast here in a minute. We'll need to get set up to do that. But there's actually one chart even dimmer than that one.
Oh dear.
It's a challenge. Yeah, it's